So in the last session, we focused on the structural or macro level, the entire health system, right? And we talked about the boundaries of the health system, the actors, the goals, and the functions, which define the architecture of the system. That's the macro level. What I'd like to do today is focus on an intermediate level, which is to look at the specific organizations where all of those goals and those functions get actually carried out, and particularly focusing on what last week or last session we called the defining function, which is the provision or delivery of actual services. And although most of what we'll talk about, what I'll illustrate mostly with personal health services, the logic is completely applicable to non-personal health services, and I'll talk a little bit about that. But we're going to now zoom in from looking at the entire architecture to going to understanding how specific organizations and programs work together in the delivery of services. The point of departure is a modification of the model that was developed by Avedis Donavidian, which we saw earlier in the course. And if you remember the session on health needs, we started with this diagram here, and we talked about how the first step in the organized social response is when a society takes a subset of the health conditions and says that those health conditions, based on scientific evidence and on social preference, require care and therefore become a health need. That's the first step of the organized social response. We're going to now look at what happens right after that initial step. And the basic idea is that once an organization or a system defines a set of conditions as health needs, then services have to be produced to meet those needs, and resources have to be mobilized to produce those services to meet those needs. So the three components of this very parsimonious model are needs, services, and resources. The great insight by Donavidian is that the relationship between those three are not direct but are mediated. And if you look at this diagram, what it tells you is that when you're planning, this is the blue arrow, the direction goes from needs, because you first do a diagnosis of what are the needs you're going to meet. You then plan to what services would meet those needs based on evidence. And then you plan for the resources you'll need to produce the services. In the evaluation stage, which is the green line, you go the other way around. You start with your resources, your physicians, your clinics, the drugs you have. You then evaluate how productive they were in generating services. And although most of the time we stop here, ideally when you really evaluate, you take the last step. You evaluate how well those services met the original needs. And this cycle, going from needs to service to resources and then back, it's the typical planning evaluation cycle. Now, in understanding those transitions from one to the other, it's this notion of mediation that was the important insight, and that allows us to establish equivalence between service equivalence to health needs and resource requirement equivalence. And that was the insight. Today we're going to look very, very superficially at these. If you have more interest, read the reading for the session on needs. Contains much more explanation on the notion of equivalence and how those are mediated. And again, in a very parsimonious way, this diagram, which is an adaptation of Donavidian's, what he calls the medical care process, shows three mediating factors, right? So let's start with resources. The first mediating factor is the productivity of resources. Productivity is an attribute of the resources. And productivity determines the capacity, and I want to underscore here the word capacity to produce services. Productivity is in a general way, is defined as a relationship between inputs and outputs expressed in physical units, okay? The relationship between inputs and outputs expressed in physical units. For example, the number of visits, which is a measure of output in terms of services, per physician or per nurse, right? Which is a measure of an input or a resource, a human resource in this case. The number of hospital discharges, an output, a service, per hospital bed, a resource or input, right? The number of surgical procedures, an output, per operating theater, which is the resource, okay? So that's the productivity. Now, productivity is not enough. Productivity determines a potential, a capacity. But it's not enough for the simple reason that you cannot stockpile services, right? You cannot say, I have all these resources, they're very productive, I'm going to produce visits and then I'll stockpile them. Services are defined because the moment of production and the moment of consumption are simultaneous. In fact, that's the definition of a service. A good is one where production and consumption are not simultaneous. A service is when those two happen at the same time, right? So when it comes to health services, you may have a capacity, but if those resources are not accessible to the population, then production doesn't happen and consumption doesn't happen. So the second mediating factor between the capacity to produce service and the actual utilization of health services is the accessibility. Now, accessibility is illustrates very nicely the idea that the health system is best understood as the relation between a population and a set of institutions, including the providers. By the way, let me just say, health resources, of course, the most important of the health resources is the human resources, but there are also other types of resources, specifically, equipment, drugs, and so forth. And when it comes to the most important, we can study what factors determine the productivity. We know that age is a factor in productivity. There are gendered differences because women workers have other roles and demands on their time and entrances. Obviously, the level of training is a question, the incentives to which they are exposed. So there are a number of determinants of this capacity to produce services. So productivity is entirely an attribute of resources. Accessibility, it's an attribute of the degree of fit between characteristics of the resources and characteristics of the population of potential users or patients. Accessibility is different than availability. Again, availability is an attribute of resources. Is the clinic available? Is there a doctor and a nurse inside the clinic? Are the drugs there? Is the equipment there and functioning? That's the availability. And availability is a necessary but not sufficient condition for utilization to happen, because those resources that are available also have to be accessible. So again, another insight by Donavidian was this idea of the fit, which then underscores the notion of the system as a relationship. Now, there's multiple dimensions of accessibility, and I'd like to ask you to give me a few of those dimensions. Tell me one dimension of accessibility one attribute of the population and the resources that if they don't fit, utilization doesn't happen. Zina.
Geographic accessibility.
Exactly. So geographic accessibility is the first and most obvious type. And if you think about it, sometimes we say, the service is not accessible, and we're talking mostly of where they're located. It's where they're located relative to where the population is located, right? It's not an absolute term. It's a measure of the fit between the spatial distribution of resources, let's say facilities, and the spatial distribution of the population. What else? So geographic is one. Another. Financial accessibility, right? Exactly. It's not, if we say the services are unaffordable, we're saying they're unaffordable relative to the income or wealth level of the population. It's again a degree of fit. It's not that they're expensive in any absolute sense. It's that they are not affordable given the resource distribution of resources in the population. Another one. Cultural accessibility is a very important one. If you have a clinic and there's no fit with the language, the actual language that people, the providers, the doctors and the nurses only speak English, and they're located in a community where people speak other languages, then there's no fit. Therefore, they're culturally. And in addition to language, which is obviously a very important cultural characteristic, there's beliefs, right? Health beliefs. If there's a total lack of fit and people think that diseases are caused by whatever forces of nature or whatever, and the providers have a more Western scientific, you have a lack of fit. You can preach and prescribe, there will be probably very low compliance, and therefore the services maybe are utilized, but they won't satisfy the needs. And that is what leads to this whole movement for cultural competencies among providers, right? To understand also the language and the belief systems of the population so that fit improves, and therefore cultural accessibility is improved. And then there's one fourth and last form of accessibility in addition to geographic, financial, and cultural. Time. And the time distribution, that's exactly right. And a way of, Christine, you were going to add to this notion?
Environmental, if you combine those two.
Environmental in terms of the...
Like if you're in a war zone or something like that, you don't have like the actual access, but that might be geographic, but I was just tying it in with time.
Right, there may be additional barriers to accessibility, which are, for example, create danger zones or like in a zone of conflict. Now, the time dimension is important, and it's part of what we could call organizational accessibility, right? If the distribution, if the opening hours of a clinic, for example, doesn't match the distribution of free time, then you have bad organizational fit and lack of ability. This is typical, by the way, clinics that are open exactly at the times when children are in school and when adults are at work. And then, when people actually have the time to go, they're closed. This is not hypothetical, unfortunately. Or when you have long waiting times and your own tolerance to delays, your capacity to delay care just doesn't fit. So again, the distribution of time on the resource side and the population side determines organizational accessibility. Yes, Jeff.
Notion of safety fit in, and I'm thinking right now of like Planned Parenthood clinics and the whole Hobby Lobby.
Right, it is related to what Christine was saying, and it's an interesting element of the surrounding characteristics. That's an extreme example or a conflict, but if you have a clinic placed in a neighborhood where you are likely to get mugged, that will reduce that, and it's both. It's interesting. It's an interesting question. There's both an objective risk to safety, but safety is also an internalized state of mind, and which is the notion of security. And if you're insecure and you don't want to risk going out, so that's almost like a psychological accessibility, right? Whether you feel that going to the clinic or to the doctor is safe. And the two examples on, say, reproductive health services in some context, there's a whole question, although that clearly would fit in the cultural dimension of stigma, right? You don't want to be seen going to an AIDS clinic, right? And therefore, or an addiction rehabilitation center. You don't want So the extent to which a facility creates a safe environment, both from physical and also from stigmatizing threats, is a very important dimension. And again, you can put it in the frame of the degree of fit between attributes of the resources, where they are located, the sort of respect for confidentiality, the protection, physical protection measures they put, and the tolerance of the population to those threats. So it has elements that are almost like a different dimension, but those are great examples of this notion of degree of fit. Okay? Yes, Usman.
What about informational accessibility? That's a big issue in developing world where you don't know if the services actually exist. Like part of the population don't have that knowledge.
That's an interesting point. I would assume that the notion of availability includes both the objective availability and the information that something is available. So I would place that, and again, remember all these frameworks are as good as they are useful. There's nothing inherently. I would place the question of information in the notion of availability. If it is there, but you don't know about it, de facto it's not there, right? So publicizing, letting it be known that something is there is, to me, part of availability. Now, once it's there, you still have the problem of it being accessible. So being located in the right place, with the right cultural attributes, with at the right level of affordability, etc., with the right level of safety, as we were talking, etc. But it's an interesting point. It's not just that you have something there, but that it is known, that there is the information about the existence, the availability is out there. Good. You see, you're helping us write this textbook because you bring all these new ideas. We'll give you credit. All right. So now all of these relationships, of course. Well, let me just finish then. Once a service is available, I mean a resource is available and it is accessible, meaning that it fits the distribution of characteristics in the population, then utilization happens. And then what? Most of our evaluation stops there, right? And we say, we produced so many clinics, so many surgeries, we delivered so many babies, et cetera, et cetera, et cetera. That's not enough, okay? In public health, we need to take the last step. And here, the intervening factor is this very important notion of quality. And again, for those of you who are interested, there are full courses in this school around quality of care, okay? So we're not going to do justice. So meeting the need is a function of the quality of services. And quality is better understood, and again, this is a contribution from Donavidian, as having two main dimensions, okay? The technical dimension and the interpersonal dimension. We tend to focus on the technical dimension, but there is an interpersonal dimension. Now, the technical dimension itself has two fundamental aspects. One is the safety of services, and the other is the effectiveness of services. Safety means that they don't produce harm, right? The worst level of quality is not only when a service doesn't meet any need, doesn't produce any benefit, but actually when it can produce harm. And here at the school we have Professor Ashish Jha, who writes extensively on medical errors, on lack of safety, and there's a whole tradition here. In fact, some of the early studies here at the school on questions of medical errors were carried out here at the school. The most recent generation includes people like Ashish Jha, who also has a blog that's very, very interesting for those of you who like to follow these topics. So there's a lot of iatrogenic harm, sometimes due to negligence, and other due to just lack of skill, and others due to organizational constraints. It's not just the individual providers who may be at fault. that's the extreme, when quality is negative, right? When far from addressing a need, you create new needs as a result of the utilization of services. And the key here to understand both safety and effectiveness, bless you, is to understand that the level of quality refers to the optimal balance between risks and benefits of any service. Any service, even taking an aspirin, has a risk, right? Any service has a risk. It's the balance of risks and benefits that defines the level of quality. And when quality is good, it's safe, it doesn't cause harm, the benefits override the risks, and it is effective. It actually produces the effect we want, which is an improvement in health. Now, not every improvement in health is a reflection of quality. It's the improvement in health that's attributable to the care, okay? There are self-limiting diseases, okay? That whatever you did, even if you didn't go to the doctor, you would get better. They are self-limited. So a big part of the measurement of quality, particularly the effectiveness side of the technical dimension, is to try to make sure that it can be attributed to the care, because that's the fraction of the health improvement that's part of quality. Okay, a famous writer, Williamson, defines quality as the difference between what's achievable given the current technologies and what's actually achieved with our practices, right? With the services we actually deliver. And there is a frontier of possibilities given the state of technology. So just like if you have a self-limiting disease, you cannot attribute that health improvement to the quality of care. Conversely, if you have a disease for which we don't have a cure, let's say, and the patient dies from that disease, that's not lack of quality, because it was not achievable. It's an incurable disease, okay? So it's between the frontier of possibilities and which is defined basically by the level of technology, of scientific knowledge and technologies, what we can do, what's achievable, and what we actually do. That's the space for quality, okay, in the technical side. And we will come back, because when you take the system as a whole, that is very much related to the notion of performance, as we will see in the next session. Now, quality is not just technical. It has an interpersonal dimension, and this is very important, and it's directly related to one of the goals that we talked about last time. Remember what goal it was? We said that the health system has 3 goals. Responsiveness, right? So responsiveness is exactly the goal that we achieve to meet by the extent to which that met is a reflection of the interpersonal dimension of quality. Okay, and it has to do, as we discussed last time, with the respect to persons, respect to their dignity, respect to their right to participate in decision making, and respect to the confidentiality, and the client orientation of services, the level of amenities, the cleanliness of the facilities, the fact that the food served in a hospital, for example, can be eaten, the amenities surrounding that, plus the access to your social networks. That is the notion of responsiveness, and it is an integral part of the concept of quality. So when quality is high, then you both meet the need, say you cure a disease, just to keep the framework of personal health services, and you achieve satisfaction. The person is satisfied. That is an outcome. And as we said last time, satisfaction is a subjective state, which is a product of everything that happens, and that in turn, that high interpersonal quality feeds back into the technical quality, because if you are satisfied, you're more likely to continue using services, to comply and adhere to therapeutic prescriptions, et cetera, et cetera. So those two dimensions, the interpersonal and the technical, interact. Now, all of this process, what Donavidian calls the medical care process, between needs, service, and resources, doesn't happen in a vacuum. There's information, as Usman was saying, information including the information about the availability of resources, and there's research that generates evidence and allows us to understand, what to first diagnose the conditions, to define which of those are needs, to have a sense of cost effectiveness and capacity, etc., and to measure everything that goes in here. And then in terms, this all happens in a framework of policies. None of this happens in a vacuum. There are policies about which conditions will be defined as needs. That's where policy definitions begin very importantly, okay? And as we said before, the same behavior can be defined as a health need, or can be defined as a crime, or as a punishment, as a divine punishment, or so none of this is fixed. It is very time and space dependent. There are policies about the types of services that can be produced and the standards of quality under which they are produced. And of course, they are policies about the type of resources. Are we going to have a mix that has more doctors than nurses, or the other way around? Are we going to rely on specialists? Policies about the physical facilities. Do we emphasize ambulatory services? Do we emphasize inpatient services? And also about the standards of productivity. You can have policies about how many visits per hour, etc. And obviously about elements of accessibility. How do you distribute? Do you use now information technology to bridge the geographic barriers, etc.? So all of this happens in a policy space that's time and place specific. So far we've assumed, we've used as an illustration personal services. I want to emphasize that all of this is applicable to what we call non-personal services. And non-personal services include environmental services that you do on the non-human side of the environment, like vector control or clean water and sanitation. And it includes massive or collective health services. So environmental and collective are non-personal services. The collective, the best example is mass education, right? Mass health education. Not one-on-one education, but when you launch a campaign and you have mass education, that's an example of a collective service. In fact, the big challenge we have in health is the huge heterogeneity of services, the output, not the outcome. The outcome, the needs are also very complex because there's biological and psychological dimension. There's huge variation among individuals. But even the services are hugely heterogeneous. In fact, it's hard to think of any other industry that has such heterogeneity. Just think under this name, health service. The range goes from true public goods to essentially what economists call private goods. Public goods are goods where, if one person uses some of that, it doesn't take away from another, and where we can't exclude anyone. An example in health is epidemiologic surveillance, right? And that is a health service. If we have good surveillance, it benefits everyone. It's a typical public good, okay? A lot of regulatory interventions, when we regulate the levels of exposure, environmental or occupational, that's a public good. And then you have strictly private goods, right? If they take your appendix out, that's it. That's a personal service, and it goes all the way in that range. You have a range around the repetitiveness of use, how repetitive it is. In economics, there's this notion of consumer sovereignty, and you acquire information about products by consuming them repeatedly. And so if you eat cereals, so all you need to do is eat cereal and then you acquire information whether you like it, whether you don't like it, and that shapes your future consumer behavior. We have goods like that, right, in health. You go for preventive services, you have routine care that's repetitive. And then you have services where there's no information from prior consumption. If you have a heart attack, hopefully that's your one episode and you want to be treated in a way where it doesn't repeat ever again, right? And you have another range going from trivial stuff, like cosmetic health services, to life-threatening. And from predictable, even if whether they're repetitive or once, they can be predictable, like elective surgery, and emergency, where there's no predictability, where you cannot anticipate whether it's going to happen to you. So along all of those dimensions, whether it's a public good or a private good, whether it is there's repetitive consumption or one time only, whether it's predictable or non-predictable, and whether it's trivial or life-threatening, this is an incredible heterogeneity of services. And this is one of the challenges in our field. And this is what makes the assessment of health system performance particularly complex.